Good evening, ladies and gentlemen, and welcome to this evening's webinar on understanding the IVF process. I'm Dr. Juliette Skinner, and I'm the Medical Director of Barbados Fertility Centre. Many of you listening to this webinar may not even have been born when this historic time cover was printed. Some of you were born but probably were too young to actually remember what this was all about. July of 1978, when the historic birth of Louise Brown happened. Mrs. Brown had a tubal factor. She had a transabdominal egg retrieval performed on a natural menstrual cycle. Yes, IVF has changed considerably in how we do it, as you'll see in the coming slides. And thankfully, while this group of scientists took over 175 attempts to reap success, we're far more effective at what we do today. Within a few short years of that historic birth, other countries were reporting successes as well. Early ones in Australia, the USA and France. In the early years, one of the big breakthroughs was the realization that by stimulating the ovaries to produce a number of follicles, a number of eggs would significantly improve the likely odds of achieving that pregnancy. And think about it, within 5 years, the actual first birth after a frozen embryo transfer was recorded, and additional applications of IVF to include things like donor egg IVF as a therapeutic option for the many women around the world that had premature ovarian failure, became a reality. There have been many, many breakthroughs over the following 20 years, and it seems somewhat naughty to actually just summarize 4 of these. But I think if we look at the breakthroughs over the decades, big ones were the ICSI in 1992, which is where the sperm was then able to be injected into an egg, and this revolutionized the management of male factor. At the turn of the millennium, the big breakthrough really was blastocyst culture, that we could extend the culture time from what was previously up to day 3 to now go to day 5, allowing further selection and optimization of results. In 2007, there was a big advance in freeze technology called vitrification that has really changed embryo freezing and actually opened the door now to egg freezing, which was not really previously very effective. And more recently, the advances in genetic testing have been phenomenal, and we're now at a very different stage in perhaps identifying genetically capable embryos. So over the next few minutes, I hope to broadly go through indications, the basic steps of an IVF process, the various outcome predictive markers, explain why it's so important to do a pre-cycle evaluation, and really try to put this all together and how do we get the best result. So the first thing is that there are many indications for IVF or assisted reproductive technology. Like Mrs. Brown, tubal factor remains an incredibly common cause, and this may be fully blocked tubes or maybe functionally deficient tubes. Male factor, endometriosis, particularly stage 3 and 4. Very rarely do these patients achieve pregnancy without IVF. Unexplained infertility is a common diagnosis. Probably 25% of couples who start the infertility road will be diagnosed with unexplained. And while we start with simpler treatments, there's a substantial percentage of unexplained infertility that requires IVF to achieve that pregnancy. In the event that we've tried simpler treatments like ovulation induction, intrauterine insemination, the next step will be an IVF cycle beyond these more minor treatments. In some cases, the simple answer of age will mean that we move to IVF rather quickly. And as you will see, the impact of age on outcome means that certainly after the age of 40, it may be a fairly quick step to go to IVF in this group of patients. For patients with recurrent miscarriage, depending on the underlying cause, there may be a need to do IVF to allow us to either time things like immune medications or to perhaps identify the genetically normal embryo in the cases, say, of translocations or other reasons for a recurrent miscarriage. For families with specific genetic conditions, genetic diagnosis now allows us to select embryos without certain conditions, and there are indications where IVF would be needed to allow their family planning options to be realized. These days, interestingly, geographic infertility features on our list. in that it is not uncommon for couples to live in different countries because of their work, and perhaps that they do look at the option of IVF as one with a far more success probability than the old conventional sexual intercourse at a certain time of the month, which carries about a chance of about 5 to 10% in one menstrual cycle. So what is the big difference between in vitro and in vivo? Well, basically, these are the key points. Eggs and sperm in vitro are put together outside the human body and the embryos are created. Our IVF stimulation regimes allows a number of eggs and hence embryos to be created per menstrual cycle. An assessment during the laboratory culture time allows selection of embryos for embryo transfer. And the basic bottom line is this offers considerably higher chances of success than our 5 to 10% per menstrual cycle, and that's just in the general population. And obviously for the majority of couples who come to IVF, they have already been trying, and it's the case that they're not achieving that 5 to 10%. So the stages that we go through would be in a preparation phase, and for the majority of patients this will involve us, odd as I know it seems, going on the contraceptive pill, which is, has been shown to improve how we will do in the IVF cycle, and it does allow the practical side of scheduling and timing and planning. For patients on a standard agonist cycle, they'll also start their Bucerin or Lupron towards the end of that time. So the big first hurdle is to stimulate the ovaries, where we use medications to induce multifollicular development. There's monitoring by ultrasound and estradiol to allow the optimal timing of the egg retrieval. And typically at an egg retrieval, we're going to get somewhere between 8 and 18 eggs. The average number is about 12. To collect the gametes then, for the female, this involves a very simple procedure called an egg retrieval, which is done transvaginally using an ultrasound probe and a needle guide. It's a simple day case procedure done using conscious sedation so the patient does not feel anything. And typically it takes about 15 minutes, and that patient will be with us for about an hour and a half to 2 hours. And essentially the recovery is largely sleeping off the medication. For the male, in the majority of time or cases, it involves the production of an ejaculate sample of sperm or semen. In some cases, it may require a testicular sperm retrieval, for example, if the male has had a vasectomy or when we have obstructive azoospermia. The big next step is really the choice of the embryologist, which is how are we going to actually achieve fertilization. So straight IVF, as it's sometimes called, is effectively insemination. We put about 100,000 sperm around each egg. And this is what we would do if someone had normal sperm parameters, a normal cohort of eggs, and the female was under 40. However, ICSI, or intracytoplasmic sperm injection, will be done if the sperm parameters were abnormal, we had lower egg numbers, or we had female factors which may influence the zona or eggshell, and potentially affect egg and sperm binding. So at older ages, endometriosis, poor ovarian reserves, these are all things that can impact at this level. And certainly we would do ICSI in these cases. Obviously, if the couple had previously undergone IVF and had a low or failed fertilization, it would be ICSI on any subsequent cycle. And we certainly do consider this an unexplained because a small percentage of these will actually be a binding issue. So what is ICSI? Rather than the sperm burrowing in the outer shell of the egg, which is shown in the top left picture, with ICSI, a special microscope or micromanipulator is used to hold the egg gently, and a single sperm is injected into the center of the egg. And this is being shown in the bottom blue picture. The embryos are then cultured in an IVF laboratory, in petri dishes, in incubators, and in controlled temperature, oxygen, and humidity settings. And there's ongoing assessment on division, rate of embryos, and grading. What we expect is a progression of embryos, so that from the initial eggs and sperm, the next day we will see how many of these have actually fertilized, and this is called the 2PN appearance of fertilization, and this is the top picture you'll see. Then they undergo cleavage to become a 2 cell, and on day 2 there will be between 2 and 4 cells, day 3 4 to 8. And at this stage we have the option of either transferring, which was done for many of the decades of IVF, or more recently in the last 15 years, we have extended culture regimes that allow us to take embryos in the laboratory as far as a blastocyst stage, which is a day 5 embryo, which is over 100 cells. And at this point, we then would select and transfer the embryos. Remember that we're not just looking at one embryo. So if you thought about what we're really looking at, we have a panel of embryos. So we might start with 12 eggs, and maybe 10 or 11 will fertilize. And then as we go through the days, we do expect that overall number of truly good embryos to reduce. And this is a fairly standard example where 12 might well reduce down to about 4 excellent quality embryos. And for example, in this case, we would have transferred 2 and frozen 2 or vitrified 2. The majority of times, that choice and selection will be based on morphological selection. This is done by a trained embryologist, and the picture on the top shows our 2 excellent embryologists at BFC. It is based on the number of cells, the appearance of the embryo, the grading, the rate of growth, and this selection may be either day 3 or day 5. But these experts basically their expertise allows them to look at the picture, for example, on the right lower side, and select which of those embryos has the best implantation potential based on the features that they have been assessing. The embryo transfer itself is very simple. It's very much like a pap smear for a woman. It is an ultrasound guided procedure, and we place the embryos gently within the uterine cavity using a catheter. The actual number of embryos that we place will vary with age, and I'll touch on that in a subsequent slide. Any surplus embryos can be cryopreserved or vitrified for hopefully siblings in time to come, or obviously in the event of failure, the next step. Following that, the woman will continue what's called luteal phase support, which is a mixture of hormones, vitamins, and in some cases implantation regimes. And then she starts, after transfer, the longest wait of her life. Before her pregnancy test, which will be 2 weeks after the egg retrieval, and about 2 weeks after that, she will then undergo an ultrasound to look to identify fetal heart pulsations. And obviously, the bottom line is that we want a live birth of a healthy baby at the end of this. And that's the core goal. So how good is IVF at achieving that? And one of the frustrating things, and I guess challenging things to understand, is no matter where we are in the world, we never talk about success without also talking about age. So whether we're at Barbados Fertility Centre in blue, the UK in orange, or the USA in green, there is a difference of the likelihood of success purely simply based on age. In the under 35s, 35s to 37s, 38 to 40s, that graph sadly goes down. And yes, as we approach the 40-plussers, you can see that success rates may still be considerably higher than what we would expect in natural conceptions. However, these do fall into a much lower range than our younger counterparts. I think it's important to understand that there are also individual predictors apart from age, so the ovarian reserve for that patient. Her underlying diagnosis to a level. Has she been pregnant before? Previous fertility does seem to confer a benefit to probability of success. Certainly, if that patient has undergone IVF before and produced good quality embryos, this again has a positive impact on the likelihood of her being pregnant over just general statistics. So just to exemplify this, what we can show you is by simply taking out, the actual good embryos versus, selected at the blastocyst stage, you can see that in all age bands, the orange bar is considerably higher than the blue bar, which is those patients who the selection basis was made on day 3 simply because of the number of good embryos present, or those where it was made on day 5 because there were a number of very good embryos to be selected between. And roughly speaking, this confers about a 20% gain. So there's no doubt that someone producing good numbers of good embryos is going to do statistically better for her age than some of her average counterparts. So why is this? Well, I think the core understanding to this point is that women are born with all of their eggs, and the number of these will decline each year, which affects the number of eggs produced and the quality of these eggs. Quality, we're really referring to genetic capability. So these eggs, having been around in the body for all these years, begin to lose that capability of successful fertilization and division. So while in our late 20s, the vast majority of our embryos are going to be genetically capable, that number changes, and by about the later 30s, this really becomes about a 50-50 answer. About half of the embryos are not actually capable. At the turn of 40, there is certainly a further change. And at 42, something like 70% of embryos are not genetically normal. And by 44, 90%. And this effectively explains to us why there's a limitation to success as we get older. So this fact, however, is very much used to decide on how many embryos we transfer. And I think that obviously there is a balance of trying to increase the chance of success by putting more embryos in, but without high order multiple pregnancies. So in other words, triplets or above. In general terms, the guide used is under 35, we would never wish to put more than 2 embryos. These are extremely powerful, and we would not want any more than a twin gestation. Over 35, the answer is typically going to be 3 on day 3 or 2 on day 5. And certainly over 40, potentially with that genetic information I showed you in the previous slide, we may consider putting more embryos for those that are having a morphological selection. I think there's always individual aspects, and that's one of the reasons why I think it's very important. These are based with a couple with the embryology results. So, for example, their past obstetric history. If they had premature deliveries, we would be very concerned about the impact of a multiple pregnancy on their safety. Obviously, suppose they had undergone a number of attempts and failures, and obviously as they get older, does this modify the sensible number to transfer? There's also another option, which is more recent, which is genetic selection. So genetic evaluation of cells from the embryo tests for chromosomal abnormalities. So effectively, does the embryo look good versus is the embryo genetically capable? The earlier techniques of PGS, which actually were first done in the late 1999-2000, lacked accuracy and really timing was incorrect. But there have been huge advances in this field with breakthroughs, and we're now at a stage of something called next generation sequencing, which does have a very exciting future. What it does require is that we culture the embryos to the blastocyst stage, and then the embryos are biopsied and frozen, so that the embryo transfer is effectively a separate procedure. The huge advantage of this aspect would be that it would allow a single embryo transfer with a high probability of success. What are the risks of IVF? Well, thankfully, IVF is a very safe process. And while, yes, we can have some patients that over-respond and produce something called ovarian hyperstimulation syndrome. So, for example, 50 or 60 follicles, that's not what we're after. I think our understanding of this condition and management has changed so much over the last number of years that, this really does now affect quite a small percentage of patients. And even if it does, we have very effective management strategies. Our biggest risk, however, is multiple pregnancy, and approximately 25% of all IVF pregnancies will end up with a twin gestation. Thankfully, the incidence of high-order multiple pregnancies is extremely low at 1%, and I think globally there's no doubt that the drive is to obliterate triplet pregnancies if possible, and even further reduce the twin rates. Multiple gestations, however, do vary with age, and in our younger patients, that may be as high as 40%. The neonatal outcome of congenital anomalies, developmental delay, chromosomal problems are equivalent for age and gestation. So if you're comparing singleton with singleton, these all lie in comparable levels. However, we all accept that a twin gestation does carry a higher risk. But I think the most important point is to date, well over 4 million children have been born through IVF. Now, the main negative of IVF is the cost. That at the end of the day, it's a costly procedure. It involves the use of, significant costly medications. But these costs do vary around the world. So at Barbados Fertility Centre, an IVF process would cost about $5,500 plus then medications of $1,000 to $4,000. In the USA, however, the base cost of the IVF is about $12,500. In the UK, the equivalent of about £4,000. And in both of the other countries, there are significant additions that are added for ICSI, for embryo freezing, for potentially blood tests. They're often not built into that fee. In the case of genetic testing, that does add, and this equivalent is about the same across the board. So IVF is a costly step, and I think that really does exemplify why getting it right is so crucial. We need to be sure that we've done pre-cycle screening. we've optimised that treatment plan, that there's careful attention to care, and we have a good IVF laboratory. Pre-treatment screening, really the ultimate goal of this is to identify factors which may affect outcome and allow modification to the treatment process. Ovarian reserve testing is very important to trying to predict the best type of protocol and the expected response. An AMH or anti-Müllerian hormone, a day 3, FSH, potentially antral follicle counts are all incredibly useful. Uterine cavity assessment, again, crucial in my view. Saline sonograms, hysteroscopies, and to a lesser extent HSGs allow us to visualise the inside of the uterine cavity and pick up what might be minor problems that could affect a good embryo implanting. Certainly ensuring that someone has a normal thyroid function and normal prolactin levels is important. And, we do screen for the risks of implantation failure or miscarriage in the form of antibodies, where we would not screen a general population couple who were considering pregnancy. And in select cases, we would screen, things like natural killer cells or cytokines. Obviously, the patient's general health is important. So there is an infective screening process. We want to be sure that she's also has effective rubella immunisation, because the impact of rubella infection in early pregnancy is catastrophic. And obviously general health screening, her pap smear, hemoglobin A1C screening for a pre-diabetic state that would obviously affect and put the pregnancy at risk. Overall, there are many things that go into planning that IVF treatment. As I said, the stimulation regimes, our pre-assessment tests and how they affect that, the monitoring, the plan of treatment, the laboratory, the luteal phase support, the implantation regimes. Every single one of these cogs, if you like, needs to be tightened to maximise our goal of success. And I think undoubtedly the best outcome needs individualised care. It's to find the best treatment option plan for you to achieve your best results. Not everyone is going to make this journey at the age of 25 when the odds are so much higher. But what we want to do is give someone their best chances. And our view at BFC is that a 1% improvement in success rate is a baby for someone, and we don't forget what we actually do. So in summary, IVF is not new. Its safety is well established, and really the risks predominantly lie with the impact of multiple pregnancy. Perhaps technology advances to allow better identification of capable embryos will move us more and more, and it is moving us towards single embryo transfer in these genetically selected embryos. And I think a huge take-home message is that millions of men and women have had their dream of becoming a parent realised because of IVF. Thank you.